Hi everyone, I'm Dr. Jenny Brown. Today we're going to talk about fertility treatment options. So different paths to success that we've used here at NRM include ovulation induction, insemination, or what we sometimes call IUI for intrauterine insemination, in vitro fertilization or IVF. We sometimes use ICSI with IVF, which means to inject a sperm into an egg to help the process of fertilization, or this stands literally for intracytoplasmic sperm injection. And then we'll often use with IVF another step called pre-implantation genetic testing, or PGT, that we'll talk about. What is ovulation induction? Ovulation induction means that we're using oral medications, meaning medicines taken by mouth, to help induce and also boost the strength of ovulation. So typically we're ovulating 1 egg a month. If our pituitary is signaling our ovaries correctly. Some people might not have a regular menstrual cycle and might not be releasing an egg or ovulating every month. And some people might have really long cycles and their ovulation is not strong. So we use Clomid as a first-line treatment for people that actually have unexplained infertility, which is a true diagnosis and a common diagnosis. It just means that we can't pinpoint the exact problem with fertilization or implantation that's happening in the body, but we do know that there is a diagnosis of infertility and we do know how to treat this. So Clomid is a medicine you would take for 5 days, typically from day 3 to 7 or 5 to 9. It increases the strength of the ovulation, and it can also cause the release of 2 to 3 eggs, essentially giving you 2 to 3 chances in 1 month for success. It does not mean if you release 2 eggs that you will have twins, or 3 eggs that you will have triplets, but it means that you have those 2 to 3 eggs as a try. Because those eggs could both be functional eggs and they could both be fertilized, Clomid does slightly increase the risk of twins to about 8 to 10%, meaning about 8 out of 100 to 10 out of 100 women who use Clomid and get pregnant would get pregnant with twins. Letrozole is another medication that we use. It's also taken by mouth, typically from days 5 through 9. And this medicine is the first line in patients with irregular ovulation or irregular periods. And it is really effective at correcting hormone imbalances and leading to a strong ovulation. So both of these medications can be used in conjunction with ultrasound monitoring and timing a trigger shot of HCG hormone, which helps to trigger at a precise time and very strongly those eggs or egg to ovulate. So here are a couple pictures of first an ovary at rest. You can see the little dark colored circles. Those are follicles that have not started maturing yet. And then at the bottom, you can see that those follicles, 2 of them have grown a little bit larger, and those are maturing or dominant follicles. So that might be an ovary that has been stimulated with Clomid to grow not just 1, but 2 eggs. So who might use insemination or IUI? We at NRM are using this treatment for mild male factor infertility, so patients with potentially a slightly lower sperm count or sperm motility, but still with enough sperm to fertilize an egg naturally inside the woman's body. So essentially we can kind of boost the sperm that are there by washing them with a preparation that gets the best, most motile sperm, and then we use a small catheter. It's typically painless. We use a speculum similar to having a pap smear, but then we take the small catheter and inject the sperm past the cervix into the uterine cavity right when we know you're ovulating. Insemination might also be done for a diagnosis of unexplained infertility, where we're trying to optimize getting the sperm and the egg at the right place at the right time, and again, getting the best, most motile sperm there. So that is a known treatment for unexplained infertility to improve success rates. We also use insemination with donor sperm that have been frozen and then are thawed. So what is the success rate? The success rate is about 10% a cycle for females under age 35 with unexplained infertility. And for comparison, after a couple has been trying for 12 to 18 months without success, the success rate per cycle is about 3% on their own. So using Clomid potentially and IUI or insemination triples that success to about 10% per cycle. Now, the success is very dependent on age, and so as you get a little bit over 35, that success will drop per cycle, and that's why as we get into our 40s typically and late 30s, IVF may be a more successful treatment and certainly is more successful per try. When we have single females or same-sex female couples that are using donor sperm to conceive, the success per cycle is about 15 to 17%. And again, for a comparison statistic, the most fertile heterosexual couple has a success rate of about 22 to 25% per month on their own. So, we're not comparing any of these numbers to 100% per month, but the reason the same-sex couple has a success of about 15 to 17% is potentially just because that sperm has been frozen and then thawed. So we're not quite at that 22% sort of peak success that we see at the max, but we're a little bit higher than couples with a diagnosis of unexplained infertility. So what does the timeline look like? So initially, we're going to start with a telemedicine consultation or an in-person consultation, but often telemedicine is easy and convenient to do from your home. This takes 45 minutes to an hour, and afterwards there will be a financial navigator available for a phone call to go over what your insurance covers and what the self-pay costs are if you don't have insurance coverage. Next would be a diagnostic workup, which takes 1 menstrual cycle or 1 month, and this involves the ultrasound to evaluate the uterus, the tubes to see if the tubes are open, and also the ovaries to determine what the diagnosis is, along with all the labs and tests that we'll get back. We're trying to establish a diagnosis, and on the ovaries, we're looking in particular for an antral follicle count. So the ovaries will look like little chocolate chip cookies, and we're trying to count those little chocolate chips, which represent the egg follicles for the month. So that's not seeing and counting every egg left in the ovary, but it's really getting an idea of the quantity for the month, and that does replenish month after month, but gradually declines over time. We'll also do a semen analysis to look at the sperm count and motility and morphology or shape of the sperm, and then we will do labs to evaluate, for example, the thyroid and make sure that it's functioning correctly, which is really important in fertility. We might want to evaluate blood sugar levels. There are some labs that are going to be individualized based on your history. After we've done all these labs and the ultrasound, we'll do a follow-up visit. Again, this could be on telemedicine, so it can be really convenient. It takes about 30 minutes, and we go over everything, and we come up with a plan that fits your needs and meets your goals. So it's really important to understand coming into this what your goals are and what your family vision is in terms of number of children, and that can help define how you take your next steps. After we've made our plan, you'll meet with your nurse. We have educational modules designed specifically for whichever treatment you're entering, and you'll order your medicines, learn how to use them, and get all set up for your cycle. That can all happen in that same cycle, the diagnostic workup, the follow-up, and the nursing visit, so that you're ready with your next cycle for treatment. And essentially then you message us with day 1 of your cycle, and your plan is already in place, and we get going. So here is an image of an insemination or IUI, where at the bottom you'll see the vagina and then the cervix leading up to the uterus, and you'll see a white catheter that's it's a thin catheter going through the cervix into the uterus and releasing millions of sperm. Those sperm are instantaneously swimming through the tubes, and they are attempting to go and fertilize the ovulated egg, which will be released from one or maybe both ovaries if there's more than one follicle. The tubes are essentially, the ends are like a little vacuum cleaner, and they sort of suck that egg up, and the sperm and egg meet in the tube and fertilize there, and then travel to the uterus to implant. We've talked about IUI, which is a basic fertility treatment, meaning everything happens in your own body, and that is something we try first as long as your tubes are open and there's adequate sperm counts and egg counts for IUI to be reasonable to start with. If IUI isn't successful, or if from the get-go we know that the tubes are blocked or that the sperm count is significantly low, we might move directly to IVF. So IVF stands for in vitro fertilization. Individuals 38 and over may use IVF as a first-line therapy. We call that fast tracking, and this has been well studied to be a very cost-effective approach given the number of women that ultimately conceive over 38. The majority do conceive with IVF. We also fast track to IVF when we know the sperm counts are less than 10 million. We really do want a post-wash or post-IUI preparation count of about 10 million or more for IUI to have a good chance of success. Like we said earlier, will move to IVF if we have not been successful with IUI after 3, maybe 4 tries. We also use IVF to make embryos when we're preparing for a gestational carrier use down the line. So the success of IVF really depends on age. The high success is in patients where the female is under age 35, and each embryo might have a 40 to 50% chance of success. Now, we can test embryos, and we'll get to this in a minute with PGT testing, and that does narrow down the embryos to the better embryos that are more chromosomally normal, and so that does increase the success per embryo to about 60 to 65%. The most important thing with IVF is time. So fertility is directly related to age, and we don't want to wait. As soon as you know that you're interested in conceiving, we want to help you proactively manage your treatments or your proactive steps at home. Time is really essential with fertility, and I think this is one of the messages that we maybe aren't taught in our 20s and 30s because we're always focused on birth control to prevent pregnancy, but really we as females need to learn more about our biological clocks and know that egg quality does decline over time. And the earlier you pursue your fertility or fertility treatment, the more successful you'll be. So at NRM, we don't have any wait. Our focus is entirely on fertility, and we meet the needs of the community. So there's no wait time at NRM to start IVF. It typically does take 1 month to prepare for IVF, and then 1 month to undergo the stimulation, meaning growing the batch of eggs and doing the egg retrieval, and then making within that month as well, making the embryos via fertilizing the eggs with sperm. Then it takes 1 month to undergo the embryo transfer. So that might be in total, say, a 3-month process, 1 month of prep, 1 month of creating the embryos, and then 1 month to transfer the embryos. Of course, there are variations depending on your plan. So as we talked about earlier, the ovaries look like chocolate chip cookies when they're at baseline, meaning they have these little dots that represent the resting egg follicles. Those are kind of the little chocolate chips in the circle of the ovary. And as we stimulate the ovaries with IVF medicines, which are small injectable medicines that the patient gives themselves once to twice a day, we will see those small chocolate chips grow into maturing follicles, as you can see in these pictures. The one on the left is a 2D version, and the one on the right is 3D. But we're measuring all these little egg sacs as they grow, and we're timing the retrieval when they're ready. After egg retrieval, the eggs are fertilized, and then they develop into embryos. And this image starts with essentially a day 4 embryo on the left, which is a morula. It's a compacted ball of cells, and then it's going to develop on day 5 and 6 into an expanded blastocyst. And these are really beautiful pictures of a blastocyst expanding. You can see the tighter ball of cells that we call the inner cell mass. That's what becomes the baby. And then the cells around the edge are called the trophectoderm, and that is what forms the placenta. The embryo actually ends up hatching out of its shell and implanting into the uterus. PGTA, or pre-implantation genetic testing for aneuploidy, is a test we can perform on blastocyst embryos once they reach that day 5, 6, or 7 blast stage. And we do this by biopsying the embryo. We then freeze the embryo, which stays in storage here at NRM and Ovation. And then the biopsy actually goes off to Ovation Genetics to analyze whether each of those embryos has 23 pairs of chromosomes. You can see an example here of a karyotype showing all the 23 pairs. This includes 1 pair, which is the sex chromosomes. Genetically female sex is 46XX, genetically male, typically 46XY. So chromosomal abnormality means that 1 chromosome might be missing, or there might be an additional in addition to that pair. So 3 chromosomes. For example, trisomy 21 is an additional chromosome 21. So chromosomally abnormal embryos might result in an embryo that simply cannot work. It cannot develop into a baby, so the embryo, when it's transferred, results in a negative pregnancy test. Or potentially it could initially implant and then result in a miscarriage anywhere in the first trimester. Embryos with chromosomal abnormalities can also result in a live birth with a trisomy, for example, Down syndrome, or trisomy 13 or 18. So embryos, for example, this embryo having that inner cell mass, which you can see on the left of the screen, a pipette holding in place the embryo. The inner cell mass is closer to that pipette side. And then the biopsy instrument is taking a sample of about 5 or 6 trophectoderm cells without disrupting the inner cell mass, but those trophectoderm cells are representative of the embryo and can give us the status of the entire embryo. With these biopsies for preimplantation genetic testing, in addition to aneuploidy or PGTA, we can also test for something called PGTM, or meaning any monogenic disorder, meaning you have a gene that you know potentially results in an affected child, for example, with cystic fibrosis or with Huntington disease. We can make a specific probe for the gene that you carry and test each embryo for that gene and determine which embryos are affected and which are unaffected. That's PGTM. There's also PGT-SR, which can detect for structural rearrangements such as translocations, where chromosomes have swapped a piece of information that might result when an embryo is created into that embryo having too much or too little of a particular chromosome. That was a lot of information and an overview of several of the treatment options here at NRM. I think it's important to know that you are in control. So our job and my job is to educate you on all the options so that you can make the decision. You make the ultimate decision. That's important. Our job is also to answer all your questions. So we really want to understand your particular challenges and help you understand the biology and physiology of conceiving so that you can feel in control. We also want you to know that fertility challenges are common. This affects 1 in 6 couples, 1 in 6 individuals. And, you know, while it's common, every situation is unique. So at NRM, we do treat you like an individual. We want to know what you think is going on. I have trusted many patient instincts that have turned out to be right. I think you know your body the best, and you are an active team member in your treatment. We also want to help you via providing emotional support. We have a lot of resources because you may not know how normal this is, but we know that this is affecting so many people in our community, and we don't want you to feel alone. We have counselors and podcasts and books, support groups that we can help. Last but not least, and I skipped through the slide too quickly, but the bottom bullet there was we want you to understand what your financial options are, what your insurance covers. We want that to be as easy as possible because we know that the whole process can be stressful, and our team tries to take the burden of you know, any financial confusion and help explain every piece as it's going. So those are some of the treatment options and solutions that we have to helping you conceive, and want to leave you with this thought that if you want to become a parent, one day you will become a parent. And we are just here to help you see what all your options are in making that happen. Please don't hesitate to contact me at drjennybrown@nrmvt.com or by calling our office, setting up an appointment. We would love to see you sooner rather than later so we can really help optimize your chances of success. Thanks so much.